There's a number inside every blood pressure reading that almost no one calculates. It takes 5 seconds. It requires no special equipment. And it tells you more about your cardiovascular risk than either of the 2 numbers your doctor writes down. I'm going to show you exactly how to find it. But before I do, I need to challenge the way you've been thinking about blood pressure altogether, because the framework most people use is not just incomplete. It is quietly dangerous. Here is the question I want you sitting with. What if the reading your physician called borderline, the one that ended with the words, "let us just keep an eye on it," is actually the reading that deserves the most attention? And what if the reading that sent someone to the pharmacy in a panic was not the real problem at all? I have spent my career working specifically with adults over 60, studying how cardiovascular risk shifts as the body ages. And the single most consistent pattern I see is this. People are not confused about whether their blood pressure is elevated. They're confused about what elevated actually means for a body that has been running for 6 or 7 decades. That confusion has consequences. It leads to undertreated risk in some people and overtreated anxiety in others. Today, I'm going to give you a complete, evidence-based framework for understanding exactly how high is too high, specifically for your age, your physiology, and your risk profile. I'm going to walk you through the numbers the research actually supports, not the vague reassurances. I'm going to explain a hidden signal inside every reading that most physicians never point out. And I'm going to tell you about a specific window of the day when blood pressure quietly causes its worst damage in older adults, a window that almost nobody monitors. Stay with me through the entire conversation because each section builds on the last, and the practical tools I give you at the end are ones you can begin using before today is over. My name is Dr. Wilson. I specialize in cardiovascular risk in older adults, and I created this space because the conversation most people over 60 genuinely need to have about blood pressure almost never happens inside a 12-minute clinical appointment. If what you hear today gives you something useful, I want you to subscribe right now. Not after the next video. Right now. Because every person who subscribes helps this content reach someone else who needs it. Let me start by dismantling a myth. Blood pressure is not a single threshold you either cross or you do not. The way most people frame it, good if it is under a certain number, bad if it goes over, is dangerously oversimplified. And that oversimplification costs people their health every single day. The Centers for Disease Control estimates that nearly 70% of adults over 65 meet the clinical definition of hypertension. But buried inside that statistic is a reality that rarely gets discussed. A substantial portion of those same adults, people who receive prescriptions based on office readings, do not have consistently elevated blood pressure when measured properly at home, at rest, over time. They were treated based on a snapshot. A single measurement taken in a clinical environment, after walking through a parking lot, after waiting 20 minutes in a waiting room, after a nurse asked 3 questions and strapped a cuff over their sleeve. That reading does not represent their cardiovascular baseline. It represents a moment. Meanwhile, and this is what genuinely concerns me, there are adults whose readings fall just inside the acceptable range who are quietly accumulating damage. Not because their peak number is dangerously high, but because of patterns in their blood pressure that a single office visit will never reveal. So rather than asking whether your number is too high, I want you asking 3 more precise questions. First, too high compared to what? A true resting baseline or a reactive spike? Second, too high for how long? 1 reading, 1 week, 1 year of consistently elevated pressure? Third, too high in which direction? The top number, the bottom number, or the distance between them? Each question corresponds to a different kind of physiological damage happening in a different part of your body. Once you understand all 3, a blood pressure reading stops being a source of dread and starts being a source of actual information. Every reading you take gives you 2 numbers. You already know that. What most people do not know is that after 60, those 2 numbers often begin moving in opposite directions. And that divergence is one of the most clinically significant signals in all of cardiovascular medicine. The top number, which we call systolic pressure, captures the force your blood exerts against artery walls the moment your heart contracts and pushes blood forward. It is the pressure wave that travels through your vascular system with every single heartbeat. The bottom number, diastolic pressure, captures the pressure between beats while the heart is refilling. It is the background pressure your arteries live with constantly, even during rest. Here is what changes as we age. Our arteries stiffen. This is not a lifestyle choice. It is biology. The elastic fibers inside arterial walls gradually lose their suppleness over time, a process called arteriosclerosis. And when arteries stiffen, two things happen simultaneously. The systolic pressure rises because a stiff artery cannot expand to absorb the pressure wave the way a flexible one would. So each heartbeat drives a sharper, more forceful spike. At the same time, the diastolic pressure often falls because the stiff artery does not recoil naturally between beats, so the resting pressure drops. The result is that the two numbers spread apart. The top climbs while the bottom stays flat or dips lower. This pattern, elevated systolic combined with a normal or declining diastolic, is called isolated systolic hypertension, and it is not a rare variant in older adults. It is the dominant form of high blood pressure in adults over 60. The majority of hypertension in this age group looks exactly like this, and it behaves differently, carries different risks, and often requires different management than the kind of elevated blood pressure most younger people experience, which typically affects both numbers roughly equally. Why does this distinction matter so much? Because isolated systolic hypertension carries a very specific risk signature. A large analysis drawing on data from the Framingham Heart Study found that elevated systolic pressure in older adults was one of the strongest independent predictors of stroke, heart failure, and cardiovascular death, even when diastolic remained entirely normal or even low. So if a clinician looks at your reading, sees a bottom number of 74, and says the diastolic looks fine, that is an incomplete assessment. The top number can still be generating real damage, even when the bottom number appears reassuring. Now let me give you the specific numbers the research actually supports, the real risk zones, presented with honesty about both sides of the threshold. The clinical trial that reshaped how the medical community thinks about blood pressure treatment in older adults is called the SPRINT trial, published in the New England Journal of Medicine in 2015. It enrolled over 9,000 adults, the majority of them over 60, and asked directly whether aggressive treatment of blood pressure produced better cardiovascular outcomes. The answer was yes, but with important qualifications that rarely survive into the simplified headlines. The trial found that targeting systolic pressure below 120 reduced the composite cardiovascular outcome, which included heart attack, stroke, heart failure, and cardiovascular death, by 25%, and reduced all-cause mortality by 27%. But it also found meaningfully higher rates of acute kidney injury, dangerously low blood pressure on standing, loss of consciousness, and electrolyte imbalances. These are real risks that must be weighed carefully, particularly in adults over 75. For adults between 60 and 74, a systolic reading consistently below 130 at rest represents the target zone. Systolic between 130 and 139 is acceptable but deserves close monitoring. Systolic between 140 and 149 is an early warning. Not an emergency, but lifestyle changes and a direct conversation with your physician are warranted. Systolic at 150 or above consistently across 2 weeks or more is too high. That needs medical attention. For adults 75 and older, the target remains below 140 systolic, but how aggressively that target is pursued depends significantly on kidney function, risk of postural hypotension, and overall health status. Systolic at 150 or above consistently remains too high regardless of age. For the diastolic, the bottom number below 80 is ideal. Between 80 and 89 warrants monitoring. Consistently at 90 or above places arteries and kidneys under sustained excessive strain. But here is the piece that almost nobody discusses. Diastolic below 60 is also dangerous in older adults. A study published in the Journal of the American College of Cardiology using data from the ERIC cohort found that diastolic consistently below 60 was associated with significantly higher rates of subclinical cardiac muscle damage and coronary events, not because pressure was too high, but because the heart muscle itself was not receiving adequate blood supply between beats. A separate study in the journal Hypertension confirmed that in elderly patients with isolated systolic hypertension, diastolic at or below 60 was an independent predictor of mortality. I had a patient I will call Margaret, 78 years old, a retired music teacher from the Carolinas. She came in exhausted and dizzy, deeply worried about her health. Her systolic was well controlled at 128, but her diastolic had drifted down to 56 over several months on a combination of medications. Her heart was not receiving sufficient perfusion between contractions. We carefully adjusted her regimen, and within 4 weeks her diastolic had returned to 67. Her dizziness resolved. Her energy returned almost immediately. Nobody had been watching the bottom number fall too low. The focus had been entirely on keeping the top number down, and in doing so, a different problem had quietly developed beneath the surface. Watch both numbers. The floor matters as much as the ceiling. Now I want to give you something most clinicians will never calculate for you during a standard appointment. A number you can derive yourself in roughly 5 seconds from any reading you already have. It is called pulse pressure. Pulse pressure is simply the difference between your systolic and your diastolic. If your reading is 147 over 79, your pulse pressure is 68. If it is 131 over 83, your pulse pressure is 48. That gap, that single derived figure, is one of the most powerful cardiovascular risk predictors available in the older adult population. A landmark analysis from the Framingham Heart Study, published in the journal Circulation, found that pulse pressure was a stronger predictor of major cardiovascular events in adults over 60 than either the systolic or diastolic reading taken alone. And that from age 60 onward, diastolic pressure actually became inversely correlated with heart disease risk, meaning a wider gap between the two numbers carried more danger, not less. Why? Because pulse pressure is a direct, real-time reflection of arterial stiffness. Stiff arteries push the systolic higher and allow the diastolic to fall lower. The gap widens, and a widening gap means the heart is generating more mechanical force with every beat, creating more stress on arterial walls, including the walls of the coronary arteries that supply the heart muscle itself. Below 40 indicates healthy arterial elasticity. Between 40 and 60 is worth tracking. Above 60 signals meaningful arterial stiffness and elevated risk. Above 80 is a serious signal. If your most recent reading was 164 over 76, most people would focus on that 164 with concern. But the pulse pressure there is 88. That number deserves equal attention to the top number, if not more. Take any reading from your last week, subtract the bottom from the top, write that number down, and bring it to your next appointment. Ask your physician to address it directly. Most would not have raised it themselves. Here is the piece I promised you at the beginning. Blood pressure is not a fixed number. It rises and falls throughout the day, sometimes dramatically, and there is one window in which it is consistently most dangerous for older adults. It is the morning surge. In the 2 hours after waking, from the moment you open your eyes to roughly 90 minutes later, blood pressure rises sharply in most people. This is driven by the release of cortisol and adrenaline as the body activates, combined with a sudden increase in heart rate and sympathetic nervous system activity. In healthy younger adults, this surge is modest. In older adults with arterial stiffness, it can be dramatic. 20, 30, even 40 points above the nighttime baseline. Research published in the journal Circulation established that the hours between 6 in the morning and noon account for a disproportionate share of strokes and heart attacks in older adults, and that the morning surge is a primary contributing mechanism. A prospective study of over 500 elderly patients with hypertension found that those with a high morning surge had a stroke risk nearly 3 times higher than those with a blunted surge, even after controlling for average blood pressure across the full day. What this means practically is that if you take your blood pressure once a day and you take it 3 in the afternoon, you may be measuring your most benign window. Your morning reading, taken within 30 minutes of waking, before coffee, before medication, before any physical activity, is far more clinically revealing. I had a patient I will call Raymond, 72 years old, a retired engineer from the Pacific Northwest. His afternoon readings were consistently around 133/77. He felt well and appeared well controlled. On clinical instinct, I asked him to take readings at 3 specific times each day for 2 weeks, within 20 minutes of waking, at midday, and at bedtime. His morning readings averaged 161 systolic. The same man who appeared well-managed in the afternoon was running dangerously elevated for the first 2 hours of every single day, through his morning walk, through his first cup of coffee, through his newspaper. We adjusted the timing of one existing medication to provide better morning coverage. His morning readings dropped to 137. His afternoon readings were unchanged. If we had never measured the morning, the danger would never have been found. Accurate readings depend entirely on accurate measurement technique. There are 5 errors I see constantly in older adults, and each one can artificially add 10 to 20 points to a reading. Combined, they can inflate a number by 30 to 40 points that have nothing to do with real blood pressure. Measuring without resting first is the most common. Blood pressure rises immediately with physical activity, even the walk from the kitchen to the chair. Guidelines from the American Heart Association recommend a minimum of 5 full quiet minutes of seated rest before any reading. Measuring over clothing or with the arm hanging is the second. The cuff must be on bare skin, and the arm must be supported at heart level. A lowered arm position alone adds 8 to 10 points due to the hydrostatic pressure of blood pooling downward. Using the wrong cuff size is the third. A standard cuff on a larger arm produces falsely elevated readings. This is extremely common and almost never verified. Ask your pharmacist to confirm your cuff size. A full bladder, crossed legs, or talking during the reading are the fourth category of errors. A full bladder raises systolic by 10 to 15 points. Crossed legs add 5 to 8 more. Talking, even briefly, adds another 10 or more. That is a potential 30 additional false points from things entirely within your control. And taking only one reading and trusting it completely is the fifth. Blood pressure varies moment to moment. Take 2 readings 1 minute apart and use the average. Then track a pattern across a full week of morning and evening measurements. The correct protocol for every adult over 60 is this: 5 minutes of quiet seated rest, feet flat on the floor, back supported, arm bare and resting at heart level. 2 readings 1 minute apart. Recorded twice daily, once within 30 minutes of waking, once in the evening, across 7 consecutive days. Average all the readings. That average is your real blood pressure. One of the most important distinctions to understand is the difference between a reading that calls for calm, methodical response and a reading that calls for immediate emergency action. A high number without accompanying symptoms is a signal to sit down, rest quietly for 10 full minutes, breathe slowly, and remeasure. In the majority of cases, a reading that appeared alarming drops meaningfully after genuine rest. Stress, anxiety, caffeine, and even the act of worrying about blood pressure can spike a reading by 20 to 30 points temporarily. A high number accompanied by specific symptoms is an entirely different situation. If your reading is above 180 systolic or above 120 diastolic, and you're simultaneously experiencing a sudden severe headache unlike anything you have felt before, chest pain or pressure, sudden difficulty speaking or understanding language, changes in vision or partial vision loss, numbness or weakness on one side of the body, or sudden severe difficulty breathing, call emergency services immediately. Do not drive yourself. Do not wait to see whether it passes. These symptoms alongside a very high reading suggest active hypertensive injury, blood pressure damaging organs in real time. Minutes matter in this situation, but also know that many people experience readings in the 170s or even low 180s with absolutely no symptoms, particularly during stress or after a measurement error. That does not require an emergency room. It requires rest, accurate remeasurement, and a call to your physician that same day or the following morning. Know the difference between a spike and a crisis. That distinction protects you in both directions. You now have a complete framework. Too high is not a single line in the sand. It is a question of which number, which pattern, which direction, and which time of day. For adults 60 to 74, the systolic target is below 130. Between 140 and 149 deserves attention. At 150 or above consistently, the number is too high. For adults 75 and older, target below 140. At 150 or above consistently, the reading is too high regardless of how you feel. Diastolic above 90 is too high, but diastolic below 60 is equally dangerous and almost universally overlooked. Calculate your pulse pressure. Below 40 reflects healthy arterial elasticity. Above 60 is a warning. Above 80 is a serious signal. Measure your blood pressure in the morning. It is the most clinically important reading you will take. Know the 5 measurement errors and eliminate them from your routine. And know the difference between a reading that calls for rest and a reading that calls for an ambulance. Blood pressure is not a verdict. It is data. And data, when you know how to read it, give you something far more valuable than fear. It gives you the ability to act precisely at the right time in the right direction. You now speak this language. Use it.